Hi, well, welcome to this section. We will be discussing cord presentation and prolapse. I am Dr. Oluwole Ayegbisi. I am a consultant obstetrician and gynecologist. I work with Obafemi Awolowo University Teaching Hospital, Nigeria. Just like every other challenges in obstetrics emergency, cord presentation is one of them. And cord prolapse especially is a great challenge in obstetrics. And as an obstetrician, you must be on your toes when this kind of a client presents to you in labor ward. Now, at the end of this lecture, you should be able to know the definitions and the types of cord prolapse. You should also understand the incident, the risk factors, and etiology. Now, you should know the complications that are associated with it and the challenges in managing them. The diagnosis must be prompt and fast. You should understand or know how to do those things. Then you should also be able to evaluate the patient promptly and manage them appropriately. Okay, by definition of cord prolapse is straightforward and is precise. Now, cord presentation is defined as the presence of umbilical cord below or at the level of presenting part with an intact membrane. Okay? Now, why the prolapse is seen when the umbilical cord has gone through the cervix just alongside the presenting part or beyond the presenting part. Now, when it is just beside the presenting part, it is referred to as what? Occult cord prolapse. And when it is beyond the presenting part of the fetus, it is referred to as what? Overt prolapse. Now, you will understand that when you look at the photographs that I'm showing, courtesy Adam, you will realize that there's cord prolapse beyond the presenting part. That is the umbilical cord that is protruding directly into the what? Into the cervix and directly into the vagina. That is a challenge to an obstetrician. Now, the incidence. It is funny enough, we don't know most of the time it's commoner with male fetuses. The reason it is not known. Most of the females don't have it, but maybe because most babies that are females are usually bigger, so they tend to occupy the lower uterine segment, and that makes it difficult for the cord to get prolapsed. Now, it is not common, as a matter of fact, but each one is a challenge to the family that it occurs. It's even a challenge to the obstetrician because it is one loss. Okay, the presentation is what? Usually, it's between 0.1 to 0.6%. So it's not very common. It's just above 1% in breech presentation. It's common with abnormal lies. Multiple presentation is a well-established risk factor to cord prolapse. Now, cord prolapse and perinatal mortality. This is where you must understand what we are dealing with. Now, for a cord prolapse, it's a major challenge to a perinatologist due to its associated high perinatal mortality. And it has been regarded to be as high as 91 per 1,000. Okay? And also, in hospital setting, prematurity, congenital malformation are usually associated with cord prolapse. And especially when a patient falls into labor before term. Such a patient, because at that time, the baby or the fetus is still small and there's a large space in the uterus, and that way there's chances for this baby to be turning all around, assuming different position, then the cord get prolapsed, especially if it's in labor. Then for home deliveries, for those that have home delivery, especially in the developed world, the challenges they have or that leads to the mortality of the fetuses are usually delay in transferring such a baby or such a woman to the hospital. That is what major factor they have. And this leads because by the time there's a prolapse, the fetal head or the presenting part gets pressed on the cord, there's asphyxia. Asphyxia means that there's reduced blood supply to the fetus, and that way, with the reduction in blood supply, babies start gasping for air, gasping for nutrients, gasping for blood. That way, there's cord compression, and perinatal fetal death is very, very, very imminent. Now, asphyxia may also result in hypoxic ischemic encephalopathy and cerebral palsy. Okay, because when there's repeated asphyxia in the fetus, there's reduced blood supply to the brain, and the baby comes out, that's when we call what I always refer to as bad babies. Babies have difficulty in developmental milestones, cannot learn in class, the baby cannot even achieve the neck control and other things. Risk factors for cord prolapse. The risk factors for cord prolapse, usually it's when the presenting part is poorly applied. And this it's when there's a space between the presenting part, whether fetal head or the buttocks, then there's a space for the cord to slip into the space between the pelvic brim and the presenting part. Now, sudden rupture of fetal membrane is a challenge, whether iatrogenic or whether spontaneous. It's a challenge and can lead to cord prolapse because most of the time in such a situation, the presenting part is not yet applied. And once that is a rupture membrane, there's leakage of liquor, and that way, cord prolapse below the presenting part, and that leads to great danger for the fetus. Now, other things that could be responsible are cord abnormalities. There's a condition called true knots or a low content of Wharton's jelly. Okay, this is also a challenge and can lead to what? Cord prolapse. Now, fetal apoxia acidosis may alter the turgidity of what? The cord and predispose to when there's repeated apoxia, it may affect the cord, and that way will lead to a cord prolapse. Other risk factors includes majorly interference, obstetric interference, procedure or manipulations in obstetrics, or especially in labor ward. And this accounts for as high as 50%. 50%. Now, so vaginal manipulation of the fetus is a challenge and can lead to rupture membrane and then cord prolapse. External cephalic version. I know you know what external cephalic version is. This is a procedure in which an obstetrician is trying to manipulate the fetus in utero, trying to turn to appropriate size to make the fetus to have what we call a longitudinal line. In that way, during the process, there could be spontaneous rupture of membrane, and that way, there will be prolapse. Then, internal pudalic version, especially during the delivery of second twin in a multiple pregnancy, is a risk factor for cord prolapse. Then, other challenges are manual rotations, artificial rupture of membrane that I've mentioned, whether spontaneous or iatrogenic, could. Then, stabilizing and induction could also lead to, because usually it goes with what we refer to as spontaneous rupture of membrane and there's prolapse. Other challenges that are risk factor, they are general one. You will have come across multiparity. In this situation, the uterus is lax, is larger in some instances and bigger than the fetus, the content, and that way there's enough space for the baby to turn. That makes such a woman or such a fetus to have abnormal lie, and there will be space for the cord to get prolapse. Then prematurity, that's clear enough, because when the fetus is smaller, there's a large space in the room for them to turn around, then the cord get prolapse. Then second twin. Now, the first delivery takes place in a multiple pregnancy. First delivery takes place. There's now a large room, and before the second twin can occupy a space, there's a cord prolapse, and it's a challenge. Okay. Now, abnormal lie that I've mentioned, low birth weight, a small baby, a big room in the sense of the womb of the uterus. That's what I'm referring to. That leads to cord prolapse. Then abnormal lie, breech presentation is also a risk factor. Other risk factor includes fetal congenital anomaly can be a risk factor. Unengaged presenting part, I've mentioned that. Polyhydramnios is a very, very strong challenge, because when there's a polyhydramnios, the process of spontaneous rupture of membrane or iatrogen or during delivery, at that point, the cord can present before the presenting part. Now, we have lower uterine segment that is placed, that has a lower uterine segment placed fibroid, can also, because that can lead to abnormal lie, and that can lead to cord presentation. Now, other challenges we have is placenta previa that could also, then I've mentioned male gender is a challenge. Now, prevention is, we always say prevention is better than cure. Now, we should understand that whatever it is prevented will not happen. Or if it's going to happen, the challenges is going to be reduced. So as an obstetrician, you must have a high index of suspicion. You must have a patient that have risk factors for what I've mentioned, and compared to the patient. So the patient must be individualized. Once you have such a patient, you must know this patient has a risk factor for what? Cord presentation or prolapse. That way, then you manage as such. Then this management, this prevention starts from antenatal clinic. Patient must be duly counseled. Early diagnosis is important. Presence of fetal bradycardia or variable fetal heart rate in labor or antenatally, you must know that most likely such a fetus is compressing on the cord. Okay, that could lead to a challenge for such a baby. Now you must avoid digital vaginal examination in women with preterm labor or preterm pre-labor rupture of membrane. But suspicion, because if you're having a suspicion of cord prolapse, that is a challenge. When you now have a cord prolapse in them, it is not an exception. Okay, what I'm trying to say is that a preterm labor or preterm pre-labor rupture of membrane of a client in labor, if you are examining such a patient, you must understand that when you are avoiding digital examination in a prom, but when you are having a suspicion of cord prolapse, it's an exception. You must be able to assess properly and then check to make sure that there are no cord presentation or prolapse in them. Then admit any suspected case of ruptured membrane. This is a very important prevention factor. Any suspected case of ruptured membrane must be admitted. That way, you can prevent imminent danger. Now, other preventions includes admission of every transverse lie, oblique lie, or abnormal lie at term. They must be admitted. Now, any non-cephalic presentation is very important to be admitted. That way, we'll be able to prevent the danger of cord prolapse. If you have a patient that has a transverse lie, oblique lie, because there is higher risk of cord prolapse. Now, inpatient care will reduce delay in diagnosis, and that is important. Once such a patient is booked in antenatal care, you must be able to recognize this risk factor. In preventing them, you have the patient admitted on the bed and have a plan management. Now, avoid or delay rupture of membrane as much as possible. Okay, if the presenting part is unengaged or mobile. Okay, especially if you have a patient that is having an unstable life. Now, other preventions includes if artificial rupture of membrane becomes necessary in circumstances described, especially if the head is not yet engaged, it must be performed by a senior obstetrician, and it is preferably performed in the theater if there will be need for immediate cesarean delivery. Now, vaginal examination and obstetric intervention in the context of rupture membrane predisposes to a patient to cord prolapse, and this must be done with caution. Okay, you must also know that artificial rupture of membrane should be avoided if on vaginal examination the cord is felt below the presenting part. Okay, now a patient is going to have artificial rupture of membrane, and the presenting part is just below the cord is just pulsating below the presenting part. Such rupture of membrane should be delayed for the time being to ensure that the danger is prevented, and that patient should preferably go for a cesarean section for such a patient. That will prevent imminent danger or perinatal mortality. Now, common presentation. Patient may present without any untoward physical signs or symptoms. That means that you have a patient with cord presentation, the patient may not even have any complaint. So there must be, like I said, high index of suspicion. Okay, the cord should be assessed during every vaginal examination, either during the preparation for artificial rupture of membrane, or after spontaneous rupture of membrane. The cord must be assessed. Now, patients may present with abnormal fetal, heart rate, bradycardia, variable deceleration. In such a patient, there must be suspicion of cord prolapse or cord presentation, and such a patient should be noted and treated appropriately. Now, perinatal mortality and morbidity increases by more than 10-fold in cases of cord presentation or cord prolapse that is occurring at home or outside the hospital facility. And that is why a high index of suspicion is important. You have such a patient in your antenatal clinic with abnormal lie, such a patient must be admitted at term. Now, if cord prolapse or presentation occurs at home, this is what must be done. immediately the patient must be considered for transfer to the hospital, really. But beyond that, where available, patients should phone the hospital immediately for counseling and what should be done. Also, such scenario must have been painted in antenatal clinic and patient has been duly counseled. If such a problem happens, this and this must be done. Patient must be in knee chest position commonly. That way, the baby or the presenting part is retracted up, and that present compression on the cord, and that way there won't be a problem. Ambulance must be immediately ordered for, and patient transfer to the what? To the hospital. Even with imminent vaginal delivery, at home, patient should still be transferred to the hospital. Okay. Now, the presenting part can be elevated manually with hand, especially when you have a support at home, or the bladder can be filled with urine. In this case, you can use normal saline. Okay, the bladder is filled with normal saline, and when this is done, the presenting part is pushed up. And when it is pushed up, it prevents the cord from being compressed, and there won't be danger for the fetus. But if this happens at home, there's really no trouble because patient is really already under your care. But there could be trouble if decision is not taken early. Okay, so cord prolapse before the full cervical dilatation, you must immediately what? You should call for help, call for assistance because you cannot take care of such a patient alone. Then there must be venous access, take consent, and such a patient should be prepared immediately for delivery in the theater. Okay, and ensure minimal handling of the loops loops of the cord outside the vagina because of spasm, and that can lead to asphyxia and fetal compromise. Okay. Now, the vagina can be, the sterile pack can be soaked in warm normal saline and vaginal packed. That will prevent the cord from having vasospasm and will prevent further prolapse of the cord outside the vaginal wall, and the temperature will be moist. Okay. There are insufficient data really for the evaluation of manual replacement of cord, okay, above the presenting part when such a patient is managed. This practice is not recommended. So it's not appropriate to have a cord prolapse and the cord is being pushed back into the cervix or into the vagina. That should be prevented. A warm, moist gauze, sterile gauze can be used with normal saline to prevent further prolapse. Now, elevate the presenting part either manually or you fill in the uterine bladder with normal saline. That way, cord compression is reduced. Or the patient lies in knee chest position. Like I said, the presenting part is retracted up, and there won't be compression on the what? On the presenting part. The presenting part will not have compression on the cord, and there won't be challenges in managing such a patient. Okay. Now, further management includes manual elevation is performed by inserting the gloved hand of 2 fingers into the vagina, just like I've mentioned. This must be done with caution, otherwise it may further encourage prolapse. Okay, if there's a prolonged decision to delivery interval, this should not happen in the hospital. Delivery of cord presentation must be done within 30 minutes, really. Especially if there is need for ambulance to transfer or elevation of the bladder is with bladder filling becoming. Elevation through the bladder might be reassuring. If there's challenges transferring patient to the hospital, if there's challenge in taking the patient to the theater, you can elevate the presenting part, and this can be done by filling the bladder, like I said, with normal saline. About 500 ml can be used to lift off the presenting part. Then you empty the bladder again just before any delivery is done, whether vaginal delivery or C-section. The bladder is emptied and the baby is delivered. Now, further hospital management includes use of tocolysis, and this is rarely done because some have advocated for it really because if a cesarean section or transfer to the hospital is going to be delayed, tocolysis can be applied, but there's no point waiting. Once there's cord prolapse and it's happening in the hospital, within 30 minutes, such delivery should be conducted. Now, cesarean section reduces the perinatal mortality and morbidity. However, when vaginal birth is imminent, vaginal delivery, maybe there's full cervical dilatation, outcomes is usually equivalent to what? Or better than cesarean section. And that can be carried out early using what? Forceps or vacuum most preferably. Now, in term pregnancy, with a gross pathological fetal heart rate pattern at the hospital or on transfer from home, okay, with severe bradycardia, cesarean section should be advised immediately. Consent taken, patient taken to the theater within 30 minutes or less. Extremely preterm gestation, in cases where you are not certain that the fetus can survive extrauterine life, a proper discussion should be made with the couple. There's a cord prolapse, but we have a prematurity or a premature baby or fetus. Now, discussion should be made about the chances of survival rate. Now, in developed countries, 24 to 26 weeks, there is high chance that such a fetus will survive. Of course, in the tropics, even here in Nigeria, we have 28, 29 weeks, even less, that are surviving. So, but such discussion must be done with the couple, and they must understand the chances of that fetus, and the decision must be made with informed consent. And such a decision should be carried further in using cesarean section to deliver such a baby. And then neonatologist or someone that can resuscitate fetus must be present. Regional anesthesia may be considered in consultation with specialist anesthetists, and the presenting part should be kept elevated if it is being administered. That is when regional anesthesia is being considered for a delivery using cesarean section for a fetus at term. Then such a time, when such is done, or the woman is lying on her side while the anesthesia is being administered. Further management includes, at full cervical dilatation, operative vaginal delivery may be considered, that I've mentioned, and that's if delivery is anticipated within 20 minutes. And as full cervical dilatation, venous extraction in an experienced hand may be considered, especially in a multiparous woman, or for a second twin, if there's severe CTG, cardiotogograph abnormalities, then venous delivery may be considered. Also, at full cervical dilatation, bridge extraction can be performed in some clinical scenario. Internal pediatric action or delivery of a secondary in a multiple pregnancy, that can be done. In a single tip bridge delivery, internal pediatric action, manipulation of the uterus or of the fetus when the presenting part is already distended the peritoneum can be done. But we must note, it is very, very important to note that about 20% of fetuses or babies born with cord prolapse usually come down with less than 7 Apgar score at 1 minute. And about 7% we have less than 7 Apgar score at 5 minutes. And that is why it's a danger, it's a challenge to the neonates at birth, especially the newborns. They have severe risk of having asphyxia. That means when such a delivery is being considered, a phone call must be made straight to the neonatologist or someone that is very skillful in neonatal resuscitation, and that way the chances of survival can be increased. Finally, during discharge, because such a woman has gone through a lot of challenges, has gone through a lot of trauma, especially if it's been transferred from a long distance to the hospital, proper counseling to avoid postnatal depression or post-traumatic stress of the challenges such a woman goes through or went through before birth, such should be considered, and proper counseling and fear of further childbirth can happen to such a woman. Such a woman should be properly counseled to note that the fact that it has happened before does not mean it will happen again. And every woman with delivery after cord prolapse or in any obstetric emergency must have this detailed counseling and proper psychological briefing. In furtherance or in future, such a patient must be noted and proper care given. So every obstetrician must understand what a cord presentation and a cord prolapse is, and you must also know that a high index of suspicion is important. Such a patient is quickly noted from the antenatal clinic, detailed counseling, and proper plan for management, especially those ones that have persistent abnormal lives, those patients that comes down with prematurity, especially preterm labor, and that way plan management is instituted, and such a patient is delivered promptly, especially with cesarean section, within 30 minutes to prevent damage or perinatal mortality. Thank you very much.